In any case, we thank you for your being here, and I'd like to introduce our next speaker, Dr. Chad Gonzales. Dr. Gonzales is a gastroenterologist in private practice here in Ogden, Utah. He completed medical school and an internal medicine residency at the University of Utah and a gastroenterology fellowship at the University of Iowa. He is an adjunct professor and clinical instructor in gastroenterology in the Department of Surgery at the University of Utah, and his special interests are the management of inflammatory bowel disease and functional gastrointestinal disorders. I find it interesting that he didn't put on here the most interesting thing, at least from the standpoint of my children who are easily grossed out, and that is his interest in fecal transplantation. And as just sort of a side comment, Dr. Gonzales and I arrived here in Ogden very close to the same time, and it's been a lot of fun to work together. We established a GI conference every month that has now been running about 7 years, and we haven't gotten bored yet. And so anyway, really excited to welcome Dr. Gonzales and to talk about gastroenterology myths and misperceptions.
Thanks for having me back again. I count it as a great honor to speak to you today and appreciate Dr. Varma and the board for allowing me to do this. And have to thank Bob for the kind words. It really has been nice to get to know him. And I count it an honor to be on his Ultimate Frisbee texting list, and have to say that I've received texts at the most strange times. It can be pouring rain, and he'll text and say, "It is under incredibly great knowledge and prediction that there will be 30 minutes of sun at 6 o'clock. We'll meet you there for Frisbee." And it's pouring. Or I'll get a text at, 10 or 11 at night, and I'm like, oh gosh, what happened? Who's texting me? And it's Frisbee alert for tomorrow morning. So I haven't, unfortunately, taken him up and actually went and did this, and that's because I'm afraid I might embarrass him because I'm so good. Kidding you, I don't really play much. They would kill me. I probably should have retitled this Gastroenterology Controversies, and really don't have any important disclosures to make other than I've been a speaker for Takeda and Abbott and a sub-investigator on a drug study of a Crohn's-related medication that's coming out that's in phase 3 trials now that I won't be discussing today. So, I'm so short, I can barely see the screen here. Myths versus fact, or true versus false. I want to talk about hepatitis C because, as those that manage hepatitis C know, the changes for hepatitis C management are coming big time right now. And I wanted to update you on this and also talk about something else, and it's completely different than hepatitis C, is colonoscopy screening, which is about 20%, 25% of what I do. So, true or false, current hepatitis C therapeutic regimens are of limited efficacy with SVR rates of 55 to 70%. I guess I could talk right here. SVR rate is if you think of SVRs in the literature, SVR means sustained virologic remission. That an SVR rate equates to cure, essentially cure rates. As if you achieve an SVR, a sustained virologic remission, a negative RNA after 12 to 24 weeks of therapy, the risk of having recurrent hepatitis C is probably less than 1%. So we hate to use the word cure, but that's essentially what it is. So current regimens are pegylated interferon with ribavirin, and there were 2 drugs approved in 2011, telaprevir and boceprevir, that slightly increased that cure rate to 55 to 70%. Are current hepatitis C therapeutic regimens complicated? True or false? We'll talk about this. Are they expensive? Yes and no. And increased side effects. So as I mentioned, 2014 will be considered one of the most important years by far and away, 2014, 2015, for battle against hepatitis C. So why does hepatitis C matter in the primary care setting? Because of CDC guidelines that were published, for screening baby boomers, those born between 1945 and 1965, with a one-time anti-hepatitis C antibody in hopes of identifying undiagnosed individuals, many of whom have advanced liver disease, and I'll talk about that. So really, this group here is the first line of therapy for hepatitis C. The U.S. prevalence of hepatitis C is about 2% of the population. It's thought that the average patient load or patient panel in a primary care practice is 2,000 patients, maybe more than that for many, and that the average practice has 40 patients with hepatitis C. Now, do we know those hepatitis C patients, those 40 patients? Not even close. And they don't even know that they have hepatitis C. So why is it important that we know this? Well, hepatitis C is 4 times as prevalent as HIV and hepatitis B, and there's estimates that upwards of 5 million people are living with hepatitis C in the United States, the vast majority undiagnosed and untreated. And this slide shows that most of those patients, up to 33% of patients who are baby boomers are undiagnosed, have advanced fibrosis. You do liver biopsy, they have sort of a stage 3 fibrosis, bridging fibrosis. We see stage 4 fibrosis, that's cirrhosis, kind of a early MELD score or a low child class cirrhotic patient. And in the next 10 years, by the end of this decade, a third of patients are projected to develop cirrhosis. So we need to catch these patients early when we can modify their disease outcome, prevent complications. So these are important milestones in management of and treatment of hepatitis C genotype 1 patients. Genotype 1 is the most common genotype in the United States. There's genotype 2, 3, and 4, 5, and 6, very uncommon. And genotype 3, for instance, is very common in Egypt. But we deal mostly with genotype 1 here. So back in 1991, standard interferon was developed, and as you can see, the cure rate or SVR rate was very, very low, increased a little bit with reformulation and with the addition of ribavirin, a nucleoside inhibitor, the SVR rates increased significantly by the end of the 1990s. And beginning in 2001, we saw a new version, a pegylated version of interferon for 12 months of therapy. They did studies to show that in addition with ribavirin therapy increased the SVR rates up to 55%. And that corresponded to about the time I was in fellowship in 2003 and 2004. But if anybody that's used pegylated interferon ribavirin know that the side effects are tremendous, and often therapy was 12 months or longer in genotype 1 patients. So it was hard to convince patients once you consented them for therapy and talked about side effects, hard to get them to move on because of those risks and those side effects. So in 2011, we saw the addition, FDA approval in mid-2011 of 2 drugs, direct-acting antivirals, telaprevir and boceprevir. I won't talk much about those now because there's been quite a new change in the way we manage this. And then in 2014, the addition of protease and polymerase inhibitors and other direct-acting antivirals that have pushed the SVR rate substantially higher. So, I want to talk about 2 drugs approved in November and December of last year. The first drug approved by the FDA was cimeprevir. It's an NS3-4A protease inhibitor for genotype 1, and sofosbuvir, a nucleotide analog polymerase inhibitor for treatment of hepatitis C, genotype 1, 2, 3, and 4. So, not very many slides here, but a very busy slide that summarizes, let me see how you can point, okay, that summarizes the data that led to the FDA approval of cimeprevir, the Quest 1 and 2 and the Promise and Aspire trial. And what they did with this is that these studies is that they looked at treatment-naive patients. These were patients who had never received treatment, patients who had previously been treated but relapsed, achieved primary endpoints, undetectable virus during study but relapsed the minute it was stopped, and then partial responders and patients who we consider as a null responder who had no response to therapy. Traditionally, these were the most difficult patients to treat, who had prior relapse or prior partial response. And what they did is they randomized patients in these studies, on the left, the treatment-naive patients with samipravir as a once-a-day medication, in addition to pegylated interferon ribavirin for 12 weeks, and then dropped the samipravir and continued for an additional 24 weeks. So this was almost a year of therapy. And, let me go back. And achieved SVR rates of 80% compared to standard therapy at 50%. And they looked at prior and partial and null responders, and these numbers were considerably better than what had been reported historically, with side effects that weren't much worse than standard therapy with PEG interferon ribavirin, but these patients were still getting the serious flu symptoms and the nasty side effects that made it intolerable for a lot of people. There are some drug-drug interactions that are important. Important to know that these difficult patients that were partial responders or previous null responders continued on for a full year of therapy. All right, so this drug was approved last November. Moving on to the drug that was approved in December, sofosbuvir for genotype 1, 2, 3, and 4. This is a combination slide of two studies that led to FDA approval, the neutrino study and the fission study. And what they did in the neutrino study is they looked at genotype 1 and genotype 4. Patients received sofosbuvir, which is a once-a-day medication with pegylated interferon and ribavirin for a total of 12 weeks. Now, this is substantially less therapy than standard therapy, which is a year. And these numbers are outstanding. And when they saw this, there's nothing that even compares historically to these kind of SVR rates for treatment of genotype 1 patients. So in genotype 4, 96% SVR rates at 12 weeks after therapy, genotype 1, 90%. They looked at genotype 2 and 3, and they did something a little bit different. They did 12 weeks in these studies and compared to pegylated interferon ribavirin at 24 weeks. And for genotype 2 patients, very high SVR rates, genotype 3, lower SVR rates. And when they looked at patients who were interferon-free patients in genotype 2 and 3 studies, the side effects were minimal. Fatigue, headache, nausea, and dropouts were rare. Less than 1% of patients dropped out of these studies for side effects. So very well-tolerated medications, especially the interferon-free regimen in patients with genotype 2 and 3. So they wanted to look at what about genotype 2 and 3? Can we change the dosing interval a little bit and achieve higher SVRs? And that's what they did with the Valence study. They looked at genotype 2 patients that received, these are interferon-free regimens, just pills, sofosbuvir, genotype 2 for 12 weeks, and genotype 3 patients received sofosbuvir for 24 weeks. And again, outstanding data. Overall SVRs of 93% and 85% for genotype 3. Treatment-naive patients did the best and performed similarly. And treatment-experienced patients who had previously received pegylated interferon ribavirin, these are the patients who were previous null responders, partial responders, or relapsers, did very good as well. So this led to consensus guidelines from the American Association for the Study of Liver Disease and the Infectious Disease Society of America, 2014 guidelines for patients who are eligible for interferon and ineligible. So the ineligible patients are patients with autoimmune disorders, decompensated cirrhotic liver disease, depression, patients who have pancytopenias at baseline, history of cardiac disease, and importantly, intolerance to interferon, who've had interferon previously and just did not tolerate it well. So, and this is available online, and these updates are these guidelines are going to be updated continually, and I'll tell you why in here in a minute. But essentially, genotype 1, currently patients are managed with sofosbuvir plus pegylated interferon ribavirin for 12 weeks. And almost all genotypes that we see in the United States are managed for 12 weeks, except for genotype 3, which is 24 weeks. Again, very well tolerated because it's an interferon-free regimen for 2 and 3. Interferon-ineligible patients essentially the same as what we do for interferon eligibles, except for the patients in genotype 1 and genotype 4, we drop the interferon from the regimen. Interesting that this is an off-label recommendation combining cimeprevir and sofosbuvir plus ribavirin. And not surprisingly, and you'll know why in just a minute, that's difficult to approve because of expense. So non-responders manage slightly different, but again with combinations of all oral agents except for genotype 3 where you give pegylated interferon as well. So this is a list of interferon-free regimens that are in late-stage development and are thought to be going to be published and released within the next 6 months to a year. You see multiple regimens across multiple mechanisms of action for viral inhibition. And PEG interferon, obviously, ribavirin, we're not even looking at right now currently. So this is projected timing for new regimen launches within the late fourth quarter of this year. And I want to talk about some new studies. These studies have been released hot off the press within the last 4 weeks, published in the New England Journal of Medicine, combining ledipasvir, which is a protease inhibitor, with sofosbuvir. These are once-a-day medications for treatment of genotype 1 patients. This is the ION 1, ION 2, and ION 3 study. It has not been FDA approved, this regimen, but we really expect it to be very soon. So, again, combines 3 different studies. We'll start with treatment-naive patients. And what you notice straight across the board is that SVR rates are incredibly high, 93 to 99% for all types of patients. These treatment-naive patients here included some early cirrhotic patients. In this study here, the ION 3 included just patients without cirrhosis for 12 to 24 weeks of therapy and very high SVRs. Most common side effects: headache, insomnia, nausea, and dropouts were extremely rare in these 3 studies. These are 3 studies that were published in New England Journal of Medicine within the last 4 weeks, comparing different protease polymerase inhibitors, nucleoside analogs with ribavirin. Again, interferon-free regimen. You take one of these pills twice a day, the rest are once a day. And this is a study looking at genotype 1 patients, the Sapphire 1, 2, and 3, 1 and 2, and the Turquoise 2 study. And they looked at cirrhotic patients versus non-cirrhotics, prior naive and prior treatment or previous treatment. And patients in the previous treatment study received 12 weeks of 4-drug combination therapy with very high SVR rates, again, cure rates at 12 weeks that are very, very high. These are non-cirrhotic patients. And if you look at cirrhotic patients, they do equally well for the most part, except for maybe a null patient in this study. Cirrhotic patients were also randomized to either 12 weeks or 24 weeks of therapy, and side effects were very, very mild, and dropouts were rare in this study. What we don't know from these new studies is how these patients respond if they have portal hypertension and more advanced liver disease. We also don't know very well with these new drugs that are coming out this year what happens if you if a patient is pre-transplant. So looking ahead to this year, study 040 published in the New England Journal of Medicine compared sofosbuvir and decladazvir. And this is looking at genotype 2 and 3 with, again, high viral loads at 89 to 92% and very minimal side effects and no anemia. So, myth versus fact. Current hepatitis C therapeutic regimens are a limit of efficacy. Well, we know that to be false. The new medications that are coming out are very highly efficacious, much less complicated. They're all oral regimens slated for this year and into next year. It is true that they remain very expensive, and I'll talk about that in a second, and side effects are minimal compared to previous therapies with combination ribavirin and interferon. So barriers to therapy. And this is a huge barrier to therapy. I listened to a national meeting, and the doctor said, these side effects are so minimal, but except for one, which is the side effect of poverty. This will make someone poor, and it'll make the United States poor, potentially. Sabosavir is currently marketed and sold at $1,000 a pill. $94,000 for 12 weeks of therapy. Gilead Sciences bought a company that developed Sabosavir for about $12 billion, and they have made, probably through this day, over $3 billion in 3 months. And it is the biggest new drug launch in history. And California estimates that to treat half of patients with hepatitis C, it's going to cost $18 billion a year. So there is significant barrier to therapy. And what is ethically right to charge a patient when they bought the company that made this for they're in the game probably $12 billion, and they're going to make that back in less than a year. So there are barriers to therapy, and we don't know what the new drugs are going to cost, the ones I talked about in the last 6 studies, but they'll be considerably expensive. They'll get what they can get, what people will pay, what insurance companies will pay. So this is switching topics completely because I felt it important to talk about colonoscopy screening. And surprisingly, how many believe that the data strongly shows that colonoscopy screening decreases colorectal cancer incidence and mortality? Well, that's kind of a loaded question. The data doesn't strongly show that, but the data strongly shows that, but it's not definitive. It's never been definitive. Does an elevated adenoma detection rate correlate with fewer cancers? Well, we've kind of thought that if you can detect more polyps, you decrease the risk of cancer. And what about missed colorectal cancers? Does that occur frequently? How frequently does that occur in Utah compared to other places around the world? So, if you read the New York Times, and it's hard to read it from way back in the room, this was actually put out in June 1st of last year, and the title is The $2.7 Trillion Medical Bill, Pain Till It Hurts, a Case Study in High Costs. And then it says, colonoscopies explain why the U.S. leads the world in healthcare expenditures. So you read that and you think, if you're a gastroenterologist, okay, this is not going to be a very favorable article for my specialty and for colonoscopies in general. And I took exception with the mention in this that maybe colonoscopy screenings are just not that effective at decreasing the risk of colon cancer. So I wanted to make light of a study that was published in the New England Journal of Medicine in September, comparing a very, very large cohort of patients, 89,000 participants in the nurses' health study and health professional follow-up study. 22 years of follow-up, they found in this time frame, in this study, that there were a total of 1,164 colon cancer cases, 349 colon cancer deaths, and that compared to no lower endoscopy, a negative colonoscopy significantly decreased the risk of incident colorectal cancer cases compared to negative sigmoidoscopy, compared to negative colonoscopy or sigmoidoscopy with previous polypectomy, and that the number of right-sided colon cancer cases were significantly decreased in patients who had a lower endoscopy, either colonoscopy, sigmoidoscopy, compared to no screening. And that the same held true for colorectal cancer deaths, that the risk of dying from colorectal cancer was lower in patients who had screening colonoscopy and much lower for patients who had right-sided colon cancers. Why? Because sigmoidoscopies miss right-sided colon cancers. In fact, the hazard ratio was increased a little bit in patients who had a previous sigmoidoscopy evaluation. So what they found is that they looked at cancers that were diagnosed within 5 years of a screening evaluation and found that more likely these patients were to have had CIMP mutations or MSI, microsatellite instability mutations. So that led to another article that was published in February by a friend at the Huntsman Cancer Institute, Jewel Sameter. And what he did, he works with Randy Burt, who just retired, and is essentially over their colorectal cancer program. And what he did is he looked at a population-based cohort of Utah residents that were taken care of at either Intermountain Healthcare facilities or the University of Utah Health Network. And looked at colonoscopies between 1995 and 2008 and linked those results with cancer histories in the Utah population database and looked at 126,000 patients that were screened, found a total of 2,659 cancers. So they defined, in these kind of studies, they've defined the detected cancer as a cancer that's detected within 6 months of that first colonoscopy. And then they looked at how many cancers were detected between 6 months and 6 years and found 159 cancers, or 6% of all cancers, were considered missed interval cancers. And they started looking at this number, and more often these patients had localized early stage disease. More often they had proximal colon location compared to distal. More often they had an adenoma at their initial colonoscopy, and more likely to have a family history of colon cancer, and more likely to have a lower risk of death. So these results in Utah compare favorably to other published results of a range of about 3 to 14% of missed colorectal cancers. But again, we're not on the lower end, we're straight kind of in the middle. So they asked, and I asked him, I bumped into him a couple weeks ago, and I said, well, what is it about these cancers? What do you think is going on here? And probably these are missed cancers because of inadequate polyp management. If you take off a polyp with just forceps instead of a snare and cautery, it's possible to leave little cells and tissue there that can regrow. And they probably think that there are biologic factors, and again, saw this on the last study, that more often these polyps go through a serrated adenoma pathway that increases and confers a higher risk of colorectal cancer. And more often they're right-sided and flat and harder to see and remove. And more often probably these missed cancers have microsatellite instability. So, how can we do better? This article was published last month in the New England Journal of Medicine looking at the adenoma detection rate. So the adenoma detection rate is the number of patients who had a colonoscopy screening with a polyp compared to the total number of patients older than 50 who had screening. And this group looked at 315,000 patients, colonoscopies between 1998 and 2010 through Kaiser Permanente. There were a lot of doctors, 136 doctors. And they found 712 interval colorectal cancers, 255 advanced stage colorectal cancers, and 147 deaths. But what they did is they looked at, and this must have been very difficult. I don't know how they did this. They must have an amazing EMR. They looked at the adenoma detection rate and divided those rates up into quintiles. So you really hate to have your colonoscopy from this guy down here who finds 7% of patients with polyps. And you really want to have your colonoscopy by this person who had a detection rate of 50%, meaning that half of all patients that they scoped had an adenomatous colon polyp. So you might say, what is a normal adenoma detection rate? And this is hard to pin down for sure, and it's probably different in different populations. But they say for women, 15%, and for men, 25%. But in reality, some are finding a lot more than this. So what did they show? Well, they showed that the adjusted hazard ratio for risk of interval cancer, risk of advanced stage cancer, and risk of mortality substantially decreases as your adenoma detection rate goes up. So for each 1% increase in the rate of detection of adenomas, there's 3% decrease in the risk of cancer. So this led, and we all know what CMS is doing with PQRS measures, the adoption of measure 343, which is a screening colonoscopy adenoma detection rate. And this is the first year that is reportable to CMS through registry reporting, in addition to measures 320 and 185, which help prevent overuse of colonoscopy screening or avoidance of inappropriate use. So evolution of PQRS, I just had to throw this up. In 2007, there were 74 measures and only one way to report, claim-based reporting. In 2013, there's 260 measures and multiple ways to report, all of them confusing in my opinion. I'm in private practice, and so I've had to sit down and try to figure this out. And I'm hoping that in the next 8 years, we don't have 1,000 measures and, 14 ways to report, even more confusion. So, myth versus fact, colonoscopy screening does indeed, in my opinion, definitively decrease the risk of colon cancer incidence mortality. Why is this important? Because, jokers like the guy that wrote the New York Times article, I take exception with that point in a big way that it's not effective. It's highly effective. Elevated adenoma detection rates important and become much more important, and your doctors should know exactly what their rate is. That has to be known so that they can, for month to month, or in my case, week to week, or even sometimes day to day, figure out why. Why am I not finding these polyps? And we know that missed colorectal cancers occur too frequently. 6% rate in Utah is too high, and we need to get that rate down to 0. We don't miss these cancers at all, and we figure out how. So, and I don't have a slide for this, but there are new technologies that are helping doctors find cancers and polyps. They have a new scope out that typically, and most people have seen it, you look out the end of it. This new scope, you look out the end and the sides, and they have 3 screens that are up. And they did this in a randomized study and looked at this, and that increased the polyp detection rate by about 3 times, which was amazing. But it's going to require heavy investment in new technology to increase this, and I'm hoping they'll find other ways to do it. What do you think the most important determinant of ADR and finding polyps is? Any ideas? Just yell it out. Time. Taking more time. Withdraw time. Absolutely. If you're taking 2 minutes to do a colonoscopy, you're missing polyps every single day. If you take, they think, a withdraw time of 6 minutes or greater, you find 4 times as many polyps as less than 6 minutes. And improved withdraw times, colonoscopy preps, all that's going to help tremendously. So thank you, and I'll take any questions that anyone has for just a minute. Do we have much time for questions? Okay, so I guess I've been told we're going to take unofficial questions, and we'll start our break right now.
I'm officially starting our break.